straight program where they would bring in community kids and say, look, this is going to happen to you if you stay on the path you're in. And the research showed it didn't have any impact on whether or not they were likely to be injured by handgun violence. It is not, the reasons why people are engaged in these violent acts have to do a lot with manhood and access to resources and adjudicating black market contracts that one can't take people to court for, settling scores between cliques, getting on people's blocks. And until we address these underpinnings of these socioeconomic underpinnings, we will never really get to the root of this. In Chicago, for example, 35% of blacks live in concentrated poverty. So that's a lot of folks. Only 5% of blacks in Chicago are in concentrated poverty. So that's both deprivation of needs individually, but also collectively. There just aren't jobs to be had. There aren't opportunities that one can access within those contexts. And that's a function of a legacy of segregation that's been outlined by social scientists and lay media for the past few years that I'm sure you guys are versed with. The solutions to that won't come from us in medicine. We may inform the efficacy of the solutions because those that come into the emergency department are really a manifestation of these social ills. And we can inform, look, this is working, we see our murder rate going down. But until we actually tackle things like dense segregation in particular, poverty segregation, we're not gonna get there. What's interesting is in the 60s, we were also tackling these things, and desegregation had a lot of momentum. There were laws on the books that allowed for desegregation, and in fact, we saw desegregation, and as a function of that, we saw educational improvement amongst vulnerable populations, we saw less concentrated poverty, and we've rolled all that back, and we are now as segregated now as we were before we attempted desegregation in the 60s and 70s. There are remaining laws on the books that, if enforced, could get us back into the similar positions that we were once in. And so you guys are an informed group or you wouldn't be here. And you've probably heard WBEZ do a series in 2015 on things like enforcing housing choice, so Section 8, where people with vouchers are supposed to be able to go to any housing anywhere in the city and are turned away and are otherwise concentrated in certain neighborhoods. You guys have probably learned about how TIF funds are being used, how funds, if a developer wants to build on public land, they have to set aside at least 10% for mixed income housing or pay into a kitty. And none of these developers are actually creating mixed income housing, they're just paying into state funds. I'm not speaking out of school, I'm just quoting from news. If those sorts of things were in fact enforced, rules that are already on the books, and segregation was lessened, particularly concentrated poverty, we would see much less violence in our streets. In the meantime, we have Band-Aids, and some of the things that really do work involve, some of the interrupters that you guys are aware of. There are Men Against Violence. There are a number of groups where people are actually out in the communities touching kids, trying to recognize the implications of their actions. But circumstances are what they are. One can only make choices amongst those that are presented to them. And if one's choices are not going to extricate them from the situation, they often lead us back into the same challenges that we see.
It was actually just something Adrian spoke about earlier, and I didn't even think about the fact that this might be happening in the medical profession. You talked about how you guys are trying to implement like some sort of bias training for physicians that more specifically don't look like us. And I'm curious kind of what does that look like? What types of biases are physicians dealing with, and how does that translate to their patient care?
But I think that everything that we see in society is reciprocated like across the healthcare system, right? So everywhere from, a patient coming in and kind of what the clothes that they have on and what they look like, the color of their skin, like those general biases that we carry kind of on the everyday life, those things come in to have an intricate part in what goes on in healthcare. So the studies there are numerous. Some of the most famous ones that come from are specifically, if you look at, I think this one came out of LA, that was looking at the amount of pain medications that were given to specifically pediatric patients by race and ethnicity, and it just showed that traditionally patients of color, young patients of color, weren't getting the same medications at the higher rate that white patients were getting. And so these things happen, right? Another one that I thought was quite interesting as well, that kind of from the sociological perspective, and I forgot who did this one, it kind of had 4 different patients, and they were all cardiac patients, and they suffered from different cardiac manifestations. And so what they did is they got providers, physicians in a room, and they kind of had them go through and kind of just read their medical record, right? And the only thing it crossed out was their name. And they kind of came up with a diagnosis. And generally there was the more appropriate diagnosis. But afterwards, when they actually saw the same patients on the video, they kind of said, like, you could see their race, their ethnicity, and their age, those diagnoses changed. And so I think that these are some of the studies that, so these studies go on, but it's kind of really the idea that there's inherent bias in the medical system as well, right? And we all have biases as individuals, right? So how do we, I think the issue really becomes, how do we become more aware of those biases, and how do we challenge those biases on an everyday basis, right? And I think that that's kind of some of the things that we want to get to in terms of medical education. And so UIC in particular, as I always like to say, is that we kind of have an antiquated medical education system. We're still doing things, quite frankly, that the same way that people who graduated there from probably actually like the 80s and 90s. It's very, very similar to how they did things. So other schools are doing a much, much better job. So I know that University of Chicago, for instance, they have like a session where you can come in for a week before you even start medical school that talks about health disparities and different things like that. So every school, as I like to say, I'm a subject matter expert on UIC. I don't know as well, but there's a lot of reports and a lot of different surveys that we read and a lot of different articles that talk about there is a conversation across the country to really kind of start to address these biases and make sure that, like, medical students, future physicians, start to address these biases as well. Because you've got to get folks when they're young. Because a lot of times, you guys can speak to this more than I can, but it's really, really challenging as you go through the medical education system, and as you get further along, it's just you're very optimistic when you start, and then as you it's very easy to get beat up on, and then you kind of just be like, oh, well, I just got this patient, and they're such and such age, and they got such and such amount of kids, well, this is just what it is. No, it's not like that. So we try to catch them when they're young. That's the idea that, that we try to implement. So.
Well, and they actually have a course where they're paired with docs in practice, and it's kind of our responsibility to take them and to expose them to patients and to provide perspective that's not necessarily medical in nature, and you want to get to them while you're young. You're right. The issue with that is, and you probably know it already, and I remember it very well, we had courses very similar to that at Rush when I was there. It's been 15 years now, but the reality is you're so busy, that's not really your focus, and so we provide these exposures for them, but it's not their focus. And literally, I'll sit in a room like this and I can look at their face and they're like, wrap it up. And so it's nice to get to them early, but the reality is they're not quite there. And another thing that I find very interesting is when it comes to biases in terms of how we perceive patients, absolutely, we all 100% have subconscious biases. We all do. And if we say we don't, we're lying. And I tell people all the time, I realize that actually my wife is Mexican. And I remember, the first time I met her family, and I'm thinking, oh, these are all really decent people. Wait a minute. Am I surprised by that? And I realized I kind of was. And so I said, I have some preconceived notions about Mexicans, and before that, I didn't think I did. And if you asked me, I would have said, well, gosh, no, how dare you, And so we all have them. But helping people see the fact that they have them is very difficult, because it requires a degree of self-reflection that nobody really wants. And I think we're kind of seeing that now when we talk about this whole thing with Colin Kaepernick and police brutality and this, that, and the other. If you don't live a certain experience, you don't know that experience. And so we were talking earlier, and I told him, talk about issues of police brutality, and they say, I think it's horrible the way the police officers are being treated, and so on and so forth. And I tell them, me, I'm 40 years old. I've never committed a crime. I've never done anything wrong a day in my life. And I can tell you that 60 to 70% of my interactions with police officers have been negative ones. Negative. And so when I see a police officer, I don't think you're here to protect me. I'm like, you're here to hassle me, Whereas great example, my colleague, his name is Dr. Weiner, he's a white Jewish guy, and his experiences have all been very positive. But his wife is Mexican. And his wife went to the bank one day and said, I'm here to pick up money from the Weiner account. And Dr. Weiner, do you know that there's something here on? And he said, yes, that's my wife. And he was so incensed, but he said what that taught him was that there are biases that people who don't look like him are subjected to, and it was very eye-opening for him. And then he taught his children, you know, hey, this is part of what we have to deal with, as, you know, as Americans, and you as a person of color. And so, you know, people don't realize that they have these subconscious biases, and I think that if they did, you could probably speak to it better than I could, but I think that if they realized that they did, it would force them to go to a place that they don't want to go to. Because if you know that you either have these biases, or if you know that these injustices are here, but you're not addressing them, then what does that say about you? So it's a lot easier to say they don't exist. I don't know what you're talking about, you know? But one other thing that I think is very interesting when it comes to patients and how we treat them, and I think we do come in with our subconscious biases for sure, but it's also how they present to us. Because I have found, and I don't mind saying that, I'm a forward-thinking people, I'm sure, but you can kind of pigeonhole patients to an extent. You know, there is your kind of classic this patient, or your classic that patient, you know? And I'll be very honest in saying that my Caucasian patients are very upfront. This is what I feel, this is what I want, this is what I expect. And so you're on notice, so you're like, okay. Whereas my Hispanic patients, my African-American patients are kind of like, this is what I feel, you're the doctor. And I'm kind of like, oh, that's nice. You know, and so it's a lot easier, but it doesn't necessarily push me to necessarily listen to everything that they're saying, you know? And so part of it is our subconscious bias, but part of it is I think we need to teach people who are black and who are brown to speak up for themselves, to have expectations, and not to be ashamed to have those expectations. Anytime I've had a patient, and again, it's not a race thing, it's more socioeconomic, but anytime I've had a patient, they will come in and say, hey, read this, what do you think, doc? I'm like, oh my God, okay. Well, you know, they're informed, and I'm gonna spend some time in here, you know? Versus when the patient says, you're the doctor, you tell me what I need to do. And while that's easier for me, it doesn't necessarily force me to do my best for the patient. So I think that that's a big part of it as well.
If I
I'm
could
sorry,
just
I'm about to moderate.
Now, it was just a brief add-on. I think it's important for us as health providers as well to make sure we're taking the time to hear the people that come to us and give special attention to those that might not have the wherewithal to advocate for themselves in the same way. I just came from a talk earlier today talking about patient-provider communication and the ways that providers often communicate with patients that completely goes over the patient's head, and they just sit there and smile and nod and go on. So I really think the onus is on us as kind of leaders in the field and people that have the data and have the information that some groups of individuals may be less likely to speak up, to make sure we're taking kind of the extra time to sit with them and pull that information, and to honor that they are the experts on them and their condition, and hear what they're saying and not just put our kind of medical psychology stamp of expertise on top of it.
For sure, 100%.
I see one in the back.
So 2 points. One, to Adrian saying that we should address it early on. I completely agree with you. If you don't think that, this is just the first point, if you don't think that that's the time to address it, then when? Because I can say right now that I'm happy to address that with my physicians. You know, there's weeks before the appointment, and you know, people nowadays go on MD, and you know, I'm trying to have the conversation with them, and I feel like too many times I'm getting brushed off, or I have to go pay money out of my pocket to get a second opinion. I feel like people think either I can tough it out, or they make decisions for me. They don't know my finances, but they assume that I should get the less expensive option. Or if I tell them that this is what it is, and I'm trying to tell you, you don't know my medical history, you just met. They're not listening. So we're putting a lot of weight on the patient. There are different types of patients, and those patients that you're talking about do exist. But I put myself in the category of I do advocate, I do educate myself, I have the resources, and I take advantage because I know that I'm at a higher risk for all of these things. And when I do that, I'm very disappointed. I guess I was kind of naive that I'm still getting poor health care. And now I'm thinking, should I just go to a black physician? I know they can do that too, but
Well,
I mean,
I think there's so many factors. One factor, unfortunately, is truly the time factor, you know? And that's why I say when the patient comes to me with all that literature, I'm like, oh, wow, how am I going to do this? I mean, literally, like, it's the time factor. And it's funny, I go to the health department in Lake County 1.5 day a week, and I went there today. I saw 27 patients in 4 hours. And literally, and so I'm in and out, and I'm thinking to myself, this doesn't feel good. I don't feel like I'm doing my best. I mean, I hit all of the things I think are pertinent, and I hope that they walk out better, but I know that they don't have a warm and fuzzy when they leave, for sure, you know? And so I think that that's one of the factors too. I mean, it's just like, there is no time. It's really tough for physicians, there's no time, and so that's why as a patient, you've got to go in there. I mean, like you said, I mean, you advocate for yourself, but maybe that's when those subconscious biases come in, and maybe they look at you like, you know, and I don't know if it's necessarily a matter of getting an African-American physician, but it's a matter of finding that physician probably who's going to listen to you, and unfortunately, fewer, you know, we're fewer and further between, and there's just so many factors that make that the reality.
So then how do we recommend exactly that sort of situation? She's trying to be informed in her care. She's trying to take part as opposed to just receive. How do we inform people to do that better from their perspective? Because I'm trying to think here, what should I recommend about that?
Yeah.
And it's difficult for me
I mean, coming
to
in
answer that.
with a knowledge base helps because, you know, you can see through the nonsense right away. I mean, sometimes, I hate to say it, but physicians will sometimes say what they've got to say to move on, you know? And so I had patients come in and tell me all the time, my doctor said this, and I'm thinking to myself, what? I mean, that's nonsense, you know, but I know that they said that because you don't know any better, and they wanted to move on to the next patient. So I think part of it is really just knowing, I mean, having a good understanding of what's going on with you, and what's already been done, and why it hasn't worked, and what you want, what you expect, you know, moving forward. And if they aren't willing to give you the satisfaction that you need, I would literally ask for an explanation. Okay, what is it that you think is going on, and why are you taking this approach, and what are the alternatives? And that absolutely forces them to say, okay, well, this is what I think. Well, why do you think that? Well, this is why I think that, you know. Okay, and why are you recommending this approach versus this, this, and this? Because the one thing that I find very powerful is, I've gotten to the point now where I will try and give patients all of the options available, because so many times they'll nail you if you don't. Well, I read about this, I read about that, I read about that. And so I think that going in there kind of with an understanding, a decent understanding of what's going on, forces them to be honest with you. But if they're still not honest with you, that's honestly when it is time to move on. And I don't know if that's, I don't know if there's anything, I don't know, but.
So inherent to this conversation on inherent biases, right? That's our biases projected onto patients. But I think that the reverse is actually probably a little bit more of a known concept when we're talking historically regarding segregation, interaction, particularly in minority communities with the healthcare system. There's the whole concept of lack of trust within the healthcare system, right? You make an appointment with someone, you're ready to have a conversation, you don't necessarily trust that they're going to make the right recommendation to you, so therefore you're a little less likely to actually adhere to that recommendation and things like that. How do we deal with concepts of trust when we're trying to build that relationship with a patient, especially when there's this huge racial and ethnic divide?
What I'm hearing are two things. One is the system is not working, right? The notion that one could effectively deliver care to 27 people in 4 hours is just, you know, it's both you and the patients are trapped in a system that isn't serving neither one well. And if you were to go to a private office on North Michigan Avenue, that just doesn't exist, right? And that has to do with the way we pay for healthcare in certain environments versus others. And that, to me, behooves those of us with influence and power, like people with MDs after our names, to be the bigger person in the relationship and to be the ones that approach with a sense of humility and openness, even when we're tired, which is part of what makes being a physician so draining and challenging so often. I also use that as an impetus to, describe how important it is that we reshape the healthcare system towards one that aligns incentives in such a way that we all think makes sense, because we're not going to solve this one-on-one. We're not actually going to make a whole bunch of doctors take the time to think carefully about their own biases every single day. Because even though we're at work every day, I mean, I think about this all the time when I train my residents. You're doing a resuscitation because somebody was hit by a car. They're never going to forget this day. You're going to go home and have dinner and come back tomorrow. Right? It behooves us to be the ones who have the influence, who have the resources, who have the experience, to be the ones that shape the healthcare system, to be the ones that are pushing back on policymakers, to be organized in such a way to make the sorts of demands that we want. Until then, my advice is to shop. Right? If you don't trust the doctor, go to another one. Right? And keep going to one until you've established, well, this is a person that I can work with. But that requires that you do some things too, right? That requires that you bring your humility to the to the interaction and ask the sorts of questions that you want to know the answer to, and be open to a style that may not be the perfect one, but if you can establish a sense of trust there, that's somebody you should just keep going back to. And if you don't find that, roll out, right? And then go find someone else. Certainly this isn't the case, you know, if you're bleeding and in pain, right, you don't have the option to shop in the same way that you can. But that is also even more impetus to establish a relationship before you become ill, right? I do not think that everybody needs a yearly physical exam. There's no research to establish that's necessary. However, if you don't have an established relationship with a physician, get one, so that when you do have something you need, this is somebody who, before the smoke of war is all around, you've actually sat down and said, yeah, I don't really have anything wrong today, I just want a checkup, but really that's your chance to talk to them.
I love it when emergency room docs talk primary care. I love
Yeah,
it.
if we can decompress my ER.
Right. I think that's a strong point to make. How many of you in this room have a primary care person? I won't say physician, but person. Actually, I haven't seen mine in like 2
I was
years.
gonna say, I
You
do I
might-
have anyone? I don't know.
All right, so that's a good number. How many are seeing their primary care provider on an annual basis? Okay, that's interesting. Do you understand why you're going annually? Has your provider ever told you that? Please.
I'm not sure how this works with HMOs versus PPO, so that may be a part of the
Yeah.
conversation that I haven't really heard talked about yet, but I go to mine regularly because he saved my entire life. So I love him, and I will see him every year, thankfully, happily.
Good.
Yeah.
And that's what we hope for, right? But it's often not the case, yeah.
I think part of it, especially as young people, is like when you're in high school, you have to get an annual physical, so you think you have to do that when you're an adult, to be frank. And you're told by your parents that you're supposed to go see your doctor annually. So, yeah, and I thought it was interesting that you said that. I was like, there's no research.
Yeah.
I feel
Yeah, no,
tricked,
there is not a single study piece of evidence that an annual visit to your doctor will make a difference with your health outcomes. There is not any sort of evidence. It is actually something from the payers that they're starting to enforce. And it is, yes, as a child, yes,
Right.
annual visits. But as an adult, I tell my 20-somethings, 30-somethings, come back when you feel bad. When you hit 40, 50, that's when we need to go annually.
Unless you,
Unless you have
diabetics.
a chronic condition that we need to do something about. And most likely I'm seeing you more than annual.
Right.
You know, like once a year we used to as women, and our OB-GYN colleague can talk about that, we used to as women be very used to doing this. But how many of you as women actually knew those rules changed? Has anybody ever told you that? Oh, that's a small number. Those rules changed. The new guidelines in 2013 actually are that you don't need annual exams in the womanly area anymore.
Very bad for business.
Very bad for his business. Great for mine. Please go ahead.
Yeah, so the question about how often you go, I used to be in the Air Force and it was all free and mandatory, so
Okay.
I get checked out all the time. That was over 10 years ago. So I met this lovely lady here about a year ago. She wouldn't, she kind of made me go. So basically, I had to be told to go to the doctor. And the company I work for, insurance is covered. I don't pay anything. Everything's covered. So I just found out a week ago I have a torn meniscus in my knee. I'll just keep playing sports and don't care. But, I mean, basically, I don't know if it's a guy thing, but they say that, and it's kind of true. I kind of think I'm indestructible, nothing's wrong with me. But she didn't make me go, and I had an MRI. I'm getting all these things done. I have like a nutritionist now. So basically, she told me to go, and that's why.
Right. So I think you hit on a very key point, and one that actually hits all of our fields as far as this concept of prevention. That a lot of our relationships in a primary care setting should really be more about preventing you from getting ill, as opposed to this health system that we have now. The way it's funded, the way it's set up is you only get to the health system when you're actually ill or sick, when instead you should be interacting with the health system to prevent those problems. Because we don't understand, a lot of us may not understand the different, ages you need to get screened for cancer, or why it's bad to be obese or eat the way you do or not exercise the way you do, or why that meniscus might be causing you a problem. If you guys don't, meniscus is in your joints, in your knees. But I think that conversation of prevention is not occurring. We think of it instead as I go to the doctor when I'm sick. But then that annual visit thing is thrown in there, and it seems like, I mean, but it's kind of a waste of time from my perspective.
Yeah,
When I used to go
tell you
annually,
why
I was like, why am I here?
You know what kind of bothered me about that? So they say that you don't need to do the annual because, you know, we do the Pap Smear, and the reality is cervical cancer, if you develop it, it's very slow growing, and if you get a Pap every 3 to 4 years, you're not going to miss it. But what bothers me about the recommendation is the whole prevention aspect, and I'm less concerned about missing a cervical cancer and more concerned about maybe, you know, not doing the clinical breast exam and missing something cancerous with the breast. But more than that, especially in minority communities, we see a lot of sexually transmitted infections, gonorrhea and chlamydia in particular. Chlamydia is 5 times more, you see it 5 times more often in the African American population. Chlamydia 5, gonorrhea 10 times more often. And 9 times out of 10, we catch it just when we did our exam. Nobody's coming in with these complaints. We just catch it on the exam. And so I'm very concerned that we're going to have people now 3 or 4 years not seeing anybody coming in with major issues. So that's just an aside. That's why it bugs me a little bit. But
what are some things that you're seeing as far as that do work outside of this forum, right? We wouldn't have felt comfortable enough to actually have a conversation about what we're feeling, what we're not feeling, how we're being treated. Like, what are some ways in which this is actually happening that you've seen that has worked besides just forums like this or health fairs?
Oh, to kind of spread this sort of information.
So did you want to go now? I've talked enough.
I was just gonna say, like, it really starts with your families with a lot of these things. Like, is that kind of where you're, like, the idea, like, of, like, how do we, like, really, like, spread the message to people who might not usually be hearing the message? Like, is that kind of?
Yeah, I mean, because, like, I wouldn't have known that, you know,
Yeah.
that about a year, that that's the research part or anything like that. But outside of me coming to this, how else would I have had the opportunity to know that?
So dissemination of, like, information.
Exactly.
Like, how do we disseminate, like, up-to-date information? Oh, well, I'm gonna take a step. I'm gonna go ahead and leave that.
This is how it happens.
Yeah.
Right? It is in fora like this that are happening amongst groups of people across the city. Usually they're run by public health officials rather than physicians. They're usually happening amongst like-aligned individuals. So it'll be a group of women or a group of kids or a group of older men. But this is how it happens. Sometimes now with social media, there are better and more efficient ways to get information. The challenge is so much of it is bad information. And not everybody who is an educated enough consumer to discern what is accurate and what is inaccurate, because there's a lot of, but once folks get good outlets, that's a very good way to get information. And some of the solutions to this yearly information, because not everybody needs an exam. One of the biggest challenges that has pared back the amount of yearly testing we do is the number of false positives that then lead to iatric injury that happens as a function of healthcare. And we've learned that we're not saving lives, we're actually making things worse. And so group visits are turning out to be really good, particularly for pediatric populations, where a lot of what happens is, you know, you get a shot, you need to counsel parents. Right? That you don't need a one-on-one visit to do that. The challenge has been, docs get paid for the one-on-one, not the group. Right? So they still have the incentive to do this 5-minute visit because they're not going to get paid if they spend 5 minutes to see 5 people. That's the job of the policymaker. We got to realign this so that it makes sense.
So good. So that's exactly what I want to get back to, because you use the phrase value-based
Yes.
care or value-based systems earlier. Can you describe that and what this trend is that a lot of payers are starting to have?
What we're trying to do, and by we I mean the royal we, all of us, are trying to do is pay for outcomes rather than units of activity, right? So instead of paying for 5 different x-rays every day, what we're paying for is you just make the person better and you're gonna get paid, right? And so over a population that requires risk on both sides, and insurance companies have much more money, so they ought to take much more risk in the equation. But if a physician is incentivized to do the right things and to have the right outcome and is paid to do it, well, it then doesn't matter to the pediatrician if they do a group visit or an individual visit. They're doing the right thing and are getting compensated accordingly. Similarly, for certain procedures, if you are doing a hip replacement, this is one of the places where you see a lot of value-based insurance design is in the implantation of devices. If you do a hip replacement and usually it costs $60,000, the insurance company says we're going to give you $80,000 per hip. If you can do it for even less than that, you get a margin. But for every person that you have that has an infection or needs to be readmitted, those might cost $120,000. They then are incentivized to improve their systems so that those sorts of negative outcomes don't happen. You get paid if you do the right thing. People get well, you're going to get paid. So aligning that and doing it efficiently is very challenging because fee-for-service healthcare is as old as medicine. Hospital centers like the VIMD are also aligned to have their margin based on these very narrow margins that are a function of fee-for-service medicine, that are a function of years of negotiation with insurance companies, and the transition is not an easy one. But at the rate at which costs are growing and the challenges that we're hearing about 27 visits in 4 hours, we gotta do better, right? Again, as I said at the beginning, I don't think I'm gonna see the solution in my professional career. I think it's gonna take multiple generations of physicians who have, and other healthcare providers who have trained in a setting where information technology is second nature, where alignment of care is just what they grew into and they didn't have an expectation of being a millionaire as a function of delivering health outcomes. That's gonna take some time. There's gonna be some generational change that'll foster this.
Yeah, because those 27, my God.
Well, that's the health department.
That's the health department.
But still, those are people.
No, I know, but it's boom,
Yeah.
boom, boom. I mean, it's-
So the idea is that the health department is making money based on each of those visits, not what the outcomes of those visits are. So that's why we're forced to keep it. I mean, I had clinic this afternoon as well too. 15-minute visits for patients that are on 10 medications. I need to talk preventative. I need to manage their hypertension and their diabetes and all this different stuff in 15 minutes. That's why we feel rushed. That's why we cut you off. That's why we are even late from the prior patient and you guys are waiting so long in the waiting room because we're trying to take good care but also fit the numbers in. And so the idea is that we need to change the system because this is how we have to practice in order to keep our doors open. So it's kind of backwards incentives. We're incentivized, actually we're paid when people are sick as opposed to paid to keep them well.
And what people probably don't realize, especially most physicians, I shouldn't say most, but a lot of physicians now, especially if they work for corporations, you get a report card. You literally get a report card, and that report card is your productivity. Now, what they're basically telling you is either you're real productive, good job, or you need to be more productive. And you need to be more productive means you need to generate more revenue. So yeah, I mean, at the end of the day, we've got to completely change the system, because like you said, we get paid to fix things, basically, So, give you an example. For a hysterectomy, if I did a hysterectomy, I probably reimburse like $3,000. Takes an hour, maybe an hour and a half, Versus having a patient come in, maybe on